Hey, what's up, y'all? I'm Dr. Italo Brown, emergency physician, and this is Med vs. Movie. Now, on the last episode of Med vs. Movie, I broke down procedures. I wanted to make sure that I got into the fine pieces of these procedures because I know that's what y'all like. I mean, let's just keep it 100%. Half of this show is straight up procedures. The other half is the inner workings and dynamics related to medical care. And I think that you need to have a little bit of both. And so on this episode, I'm going to go back and forth between dynamics, procedures, dynamics, procedures. All right. For the folks who haven't watched this, man, stop it. At this point, we're just gonna roll with it because I feel like I've given y'all enough time. I've given folks enough time to catch up. So if you're not caught up, oh well. All right, let's get this thing rolling.
What do we have?
45-year-old Silas Dunn fell off an 8-foot ladder. Right chest hit the carpeted floor. No LOC, good vitals, no meds, no allergies.
So on this part, it looks like they've got this guy who's coming in after falling from a ladder. This is something that happens, I wouldn't say like all the time, but I've had a whole lot of patients in my career who've fallen from ladders for a variety of different reasons. Excellent. I love the fact that they are bringing them in, observing proper C-spine precautions, transferring him appropriately. Yeah, all of this good stuff.
Dr. Garcia, can you spell world?
W-O-R-L-D.
Start with D, spell backwards.
So asking somebody to spell the word world backwards is one of our quick neurological tests to make sure that somebody is not having an off GCS or their Glasgow Coma scale.
No pericardial effusion. Oh, tender?
Yeah.
Okay, ribs 7 and 8, MCL.
You probably cracked a rib or two.
Check for lung sliding. Could be a pneumo. Oh, I was gonna paint the living room next.
Looking for lung sliding on the ultrasound. These are things that I've kind of brought up in previous episodes, but when you have someone who's had that type of a fall from a certain height, you're worried about crush injuries, you're worried about fractures. If there's a bleed as a result of a fracture, it's something that you want to capture. Obviously, you're thinking intracranial stuff, but because he has what they're seeing as a normal neuro status, this is reassuring. But I have a feeling it's going to kind of take a little bit of a turn. Let's look a little bit further.
No, I think renovations should be treated like dental care. Leave it to the professionals. They're the only ones should be climbing on ladders.
Is my family here yet?
Oh, I'm not sure. We'll check. How was the CT?
Head and neck normal, but tech found a small hemothorax on the right.
I swear my man looked like the weekend. Maybe the weekday. Midday, something. Oh, God.
Oh, what's that?
It's a little bleeding around the lung where you broke a rib.
He's also been more short of breath since after the scan.
Okay. They're giving you all of the verbal cues to think about a particular diagnosis, as well as the fact that this guy is probably going to transition from stable to unstable. They said that since he got back from the scan, he's had worsening shortness of breath. Now I'm worried about the lungs. Obviously, from the mechanism of the injury, they kind of saw the bruise already. There's probably a concern of multiple rib fractures, but did those rib fractures actually puncture the lung?
Stuff from the pain? Silas? Hey,
My man just stopped talking.
Lost the radial pulse.
Damn.
Ready carotid. His BP's crashing. I think he might need a chest tube.
You're right. As I
Another
suggested.
hemo Q, get type specific from the blood bank. BP 72/44, pulse ox to 89.
I got asked one time in the comments, why is it that when someone has like a pneumothorax or tension pneumothorax, the reason why they end up having blood pressure issues? And it's because, as again, that mediastinal pressure builds up, it compresses chambers of the heart, right? And so as you get that compression, the heart's not pumping effectively, it continues to apply pressure on different arteries. And then so you will see concomitant shifts in all of these different vital signs, which is what I think helps to trigger, or rather signal, the fact that this is imminent and problematic needing of a chest tube ASAP. All right.
BP 72/44, pulse ox to 89. Just dropped his BP and SATs.
Right.
Put him on 9% non-rebreather.
Call for 2 units.
Already done.
Normal head CT, small hemothorax on the right.
Really, really cool thing is being able to access the images right then and there. I think that most providers have gotten accustomed to looking at the images by themselves. If you are a trainee, you should be doing this. Like, there's nothing like actually appreciating the anatomy and seeing where the deficit is for yourself instead of depending upon the radiologist read. One, because sometimes it takes forever to get that read. And two, sometimes that read is maybe a little off. And with your own eyes, you might be able to appreciate something that the radiologist can't see because the patient's not physically in front of them. So I always look at the scans. I make sure that I look at the x-rays as well as, especially on our traumas, so I can visualize things that maybe the radiologist is going to see and act sooner.
Blood. Prep for a chest tube, 20 French.
I would love to do the chest tube.
You got it. I'll guide you.
Of course you want to do this chest tube.
Until after the chest tubes, we wouldn't want to cause a tension pneumo.
You won't make that mistake again.
All right. So
Timblade to Dr.
this
Santos.
is a hemothorax. Pause. Earlier I mentioned that maybe a tension pneumothorax. It sounds like they've looked at the imaging and declared that this is a hemothorax that's actively expanding. So the person is having a greater amount of bleeding and is causing this respiratory decline, causing all of the vital signs to continue to drop. So the low blood pressure is more than likely because this person is going into hemorrhagic shock, or is in hemorrhagic shock, not going into. They fully in it if they didn't have any pulses.
There's a lot of breast tissue.
Focus on the chest tube.
Fifth intercostal space, anterior axillary
That was
line.
interesting.
Perfect.
Nice. Good location.
Long Kelly next.
Fuck! Oh my
Oh,
god.
hell no. Hell to the no. She gotta go, man. What? Oh, hell no. Friends. You cannot be dropping sharps into somebody's foot. You can't do this, yo. I mean, bless her heart, because on one end, she's like super, super smart, and it's clear that she is a rock star. The problem is that eagerness and her movement, you know, she got to back off. She got to back off a little bit. Now she messed around and dropped this scalpel into the damn surgeon's foot. Bro, you got to chill. Now that's an entire secondary issue. The trauma by itself. Look, man, we need to do all the tests to make sure this person doesn't have hepatitis, doesn't have all these other types of conditions, because now you're talking about transfer of bodily fluids from one person to another person, which is all bad.
You okay?
Oh, that's gotta hurt.
Leave it, but
Okay, I'm stepping in.
Nope, you're not gloved. I got this.
Okay, so you
I'm
just
on my
basically
own.
a gangster. She said, leave it. That's some thugged out stuff to do.
Glove up. You're sewing this in.
I'm not mad at it though. Now she being petty. Got
We're
it.
good. No need to hover.
Hey, we'll be next door if you
That's
need
wild,
me.
yo. Word to the wise, hold on to the scalpel, no matter what. And when you have sharps and you're moving around other people, you can always request for more space. You can always place the sharps in a tray, like a mail stand to a side. All of those things you can get while you're doing it or in the process. I have had needle stick injuries. I've seen other people have needle stick injuries. I've never seen someone just like drop a whole scalpel into a foot. That to me constitutes a stern talking to and conversation right afterward, because I don't know, you know, I can't live like that. I can't live like that. So in this next case, it looks like there was a patient that they had earlier who was involved in a motor vehicle collision. They were escaping something and he ended up hitting a tree. And in these types of car accidents, you see certain types of injuries that become almost pathognomonic for head-on collisions or collisions against fixed objects like trees, poles. And so I'm interested in seeing where we go with this case.
We ready to go in here?
Getting there.
You good?
Absolutely.
Start feeling lightheaded, just speak up, okay?
I just cut that.
You're gonna pretend you're a pirate with your foot on a keg of rum.
Oh,
Are you
nice.
serious? Yep. This is the Captain Morgan technique for hip reduction.
Hey.
Here's Captain Morgan.
The guy in the rum bottle?
This is high quality, y'all.
I'll stabilize the pelvis.
Okay, you're gonna step up here.
Actually, I might just.
Yeah, and you are gonna put your right leg behind his
Giving
knee.
excellent
this?
instructions. The positioning is
and
perfect.
you are gonna use your leg as a hinge to put anterior force
Like a
on his
fulcrum.
femur.
Physics.
Push down
Yeah.
on the lower leg with your left hand.
You got this. Put your back into it. The hip is a big joint with lots of muscle stabilizing.
Okay.
Boom!
She's in the gang.
That is
She's
what
gonna be a fire ER physician. There's no way around it. After you do your first reduction, it's like intoxicating. You're like, I gotta get it again. I gotta do another. Bring on the shoulders, bring on the hips, everything. So as I mentioned, car accidents can lead to posterior hip dislocations. And when you get this mechanism, like hitting an object really hard and your foot's like smashing on the gas, it just drives all the pressure and force, like that vector is against the direction of the joint. And it's right around the part of the joint that's a little bit more shallow. And so it pushes it right through that cup. And you end up with this situation here. What I think is really cool is every single step that they listed and named is exactly how we learn how to do those hip reductions. We talk about how that is a big joint with all these muscles around it, and you have to be able to create enough leverage in doing that Captain Morgan technique in order to appropriately get the leg elevated, as well as the stabilization of the pelvis, like lots of pressure keeping the pelvis down, and so you can get that joint in place. It is a super gratifying feeling. It's one of the things about emergency medicine that I love doing reductions. And so I can totally understand why they had to show this. And I appreciate them for giving you not just the explanation, but showing you kind of the real time speed of the reduction. The one thing that doesn't really happen like this is usually you're given medications to kind of sedate and make the patient more comfortable. And that might take some time. But once the joint is in, you hear that clunk, all is right with the world. Let's keep it going, man. I feel like they've been giving us some really good pathology here. I saw another part that I think we should look at, all right? Check this out.
Dylan, when did the pain start?
Started like an hour ago.
Did you get kicked or hit with a ball or anything?
No, it just came out of nowhere.
One of the things that in emergency medicine that we don't often highlight is urological emergencies. That's right. Things that are related to male anatomy, they often don't get covered.
I need to do an ultrasound to make sure your testicle didn't twist on itself and cut off the blood supply. Is that all right with you?
So this is a guy that's coming in. He's in significant pain, probably has nausea and vomiting. All of this to me in a young person screams like, all right, where is this issue? Is it in the groin? Is it actually the belly? And you really see quickly that they narrow it down to the testicles.
There's no blood flow here at all.
Is that dangerous?
If it goes untreated for more than 6 hours, he could lose a testicle.
I could lose my balls.
One testicle. And we're going to try and prevent that.
What the hell were you doing, Dylan? I'm taking that lock off your door.
It's difficult to know what causes a torsion, unfortunately. Dylan, hey, it's really important that I try and fix this.
Testicular torsion is like my worst nightmare. It's something that I wouldn't wish upon my worst enemy, because it's basically a part of that testes spinning on itself and coiling. Like imagine you had a couple extension cords and you just twisted those over and over again until it turns into a bundle. That's testicular torsion. Imagine that being like the most pain that you can think of. And the big issue here is time. You have to be able to detors that before the blood flow to the testes or the testicles in general is disrupted.
At the time, the torsion is to the inside, so we rotate outward by opening the book.
Testicle might have twisted the other way.
Let's go back 180 and then try another 180 to the inside.
That's good. It feels...
And so the way that she talks about doing this technique is called an open book technique, just like I'm opening a book. Boop, boop. You want to have it go counterclockwise on one side, clockwise on the other side. Just go in the opposite direction of the torsing. So most commonly it's going to torse inward. You want to open book the testes. And then you sometimes have to go more than just one revolution because it is torsed significantly. This is, again, one of the bread and butter emergency medicine techniques that we have. If you are enjoying these breakdowns, make sure that you like, comment, and subscribe to Med vs. Movie. All right, y'all, I promise you that the next few episodes you're gonna wanna watch and stay glued to because I'm going in depth on each of these real critical cases. All right, Dr. Italo Brown, signing out.